I do know that one.
Where are your parents? Look at they're taking pictures of the slides.
All right, welcome back. We are going to resume, and it's my pleasure to introduce the next two speakers for a really exciting session. This is titled My Brain and Its Health, and we're going to talk about tumors, but we're also going to talk about where the tumors are, and that is the brain, and how to maintain brain health and optimal brain function throughout the tumor or cancer journey. So our next session is going to focus in on cognitive, emotional, and psychosocial well-being. This session will highlight common areas of distress and strategies for restoration and quality of life for the patient and for the caregiver. And we have two phenomenal presenters here with us who are going to conversationally walk through their thought process and approach to these topics. First, on my immediate left is Dr. Ashlee Loughan. Many of you will know her. She is a common face and presence at the ABTA meetings and is really just an expert in this area. She's a clinical neuropsychologist and an associate professor at VCU. She is director of the Live Now laboratory at Massey Comprehensive Cancer Center, and she's committed to conducting practice-changing research towards improving life and quality outcomes for patients with brain tumors and their loved ones, and you'll hear about some of her work. Here with her, on her left, is Dr. Kelcie Willis. Really excited to have Dr. Willis here with us. She is an NCI-funded postdoctoral fellow at Mass General. She's a clinical neuropsychologist by training and received her PhD in clinical psychology from VCU in 2023. Woohoo! That's right. And her research seeks to improve quality of life of patients and caregivers in neuro-oncology. So I'll turn it over to them for this conversation.
Thank you so much.
Thank you. Oh, I actually don't need this. I'm left-handed, so this is difficult for me. Okay. Okay, let me see if I can figure out how to, we don't have any disclosures. And we already introduced ourselves, and the session format is going to be very informal. We're basically going to talk to you guys about what we do, about what we know. We're going to ask each other questions. We do have some slides just to keep us on track, because we could talk for hours and hours, and you'll be booting us out of here if we didn't have that. We are going to talk from both the patient perspective and
the caregiver perspective. So Dr. Loughan and I go way back. This is my mentor for the past 5-6 years. And she is the one that made me fall in love with the field of neuro-oncology. We're both clinical psychologists, so we're going to be speaking from the perspective of mental health, cognition, emotions, behaviors, all of those things. Ashlee is a neuropsychologist, so she specializes in the cognitive components, but also is well-versed in the emotional components. And I specialize in psychotherapy for patients and caregivers with brain tumors. She's going to speak from the patient perspective today. We'll probably interrupt each other a little bit.
Yes.
And I'll be speaking from the caregiver perspective.
Wonderful. So here we're going to go over a couple things. I'm going to be talking to you a little bit about what we know about the cognitive functioning of our patients, what they endure mental health, and some strategies. Our hope is that you guys take a few pearls of wisdom home with you on how to improve your day-to-day functioning. So my first question is, who here that is I will say survivor, but I actually love the term thriver. Who here is a thriver and has noticed changes in their thinking following diagnosis? Lots of hands. Okay, without giving a side eye, who's a caregiver and has noticed changes in the patients since diagnosis? I don't want to cause any fights. But you're right, almost everybody raised their hand. Up to 90% of our patients report cognitive concerns following being diagnosed with a brain tumor. And these can be all different kinds of cognitive issues. The most commonly reported, I would say, is memory changes, not long-term memory. Long-term memory and routine stays pretty much intact. It's that new learning. What was I supposed to get at the grocery store? What did my partner tell me? what medication was I supposed to take and when was I supposed to take it? Did we already have this conversation? Things like that. Also, slowed processing. They tell me it's not that I can't get from point A to point B, it's that it's just taking me 2 to 3 times longer to get there. And also another common one is language, word finding. That, what was that word? I can't remember that word, and it may come to them in a minute, it may come to them in an hour, it may come to them in a week, or may never come back to them.
So you're naming all of these different things that people struggle with. Why do they struggle with these different problems?
Great question. So there's multiple reasons. The first is the obvious, which is the tumor located within the brain. So obviously, having something there in the brain network and circuitry can disrupt our thinking, and also the aggressive treatments that come along with that. So the first one being surgery. We go in, we take as much of that tumor out as absolutely possible, which can be good, right? It actually can improve thinking in the immediate, but also they're cutting into the brain's network, and so there can be effects from that. Then we have radiation and chemotherapy. We know from radiation, kind of layman's terms, the way I think about it is radiation kind of puts any cells that are still there to sleep for the time being, but through time, 3 months, 6 months, a year, it builds scar tissue around the areas that it was focused. And so it's hard for our networking to happen when there's scar tissue there. Chemotherapy, we've actually learned that it's not that it causes an inability for the brain to function, it's that you're actually working twice as hard to produce the same task as you were before. So me compared to some of my patients, we're gonna get to the same end goal, but it's gonna take them twice as much or 3 times as much effort to get to that goal, which can be very fatiguing. And then there are multiple medications, which can also, steroids, seizure medications, which can impact the brain's functioning.
Yeah, and it depends on where the tumor is, right?
It absolutely does. So not only are certain eloquent areas, I'm sure you've heard your physicians talk about that do language, do motor, but there's also a lot of, like I said, circuitry where the networks have to be ongoing, and if there's something that has been cut or in the way of that or pressing against it, it impacts your ability to think and function.
So at VCU, you see a lot of patients for neuropsych testing, and you'll test them earlier on in their treatment and then maybe multiple times throughout their treatment. After you tell them that they're having some cognitive issues, what strategies do you give them to manage this?
Great question. Into the next slide.
It's like I planned this.
Yes, there's a lot of cognitive strategies that we give to our patients. I have it up here listed, most of the common ones that I tell. I'm not gonna go over each one because that would take hours, but I do wanna talk about a few of them. The first one is intentional exercise and activity. So that's not only good for our physical functioning, but it is great for our brain health. Studies actually show, compared to medicine that we have available for thinking, that just a couple days a week of light exercise, I'm not talking about going and running a marathon, I'm talking about for some, just getting out to the mailbox and back has better benefits for cognition than the medicine. Taking in small chunks of information at a time. So prior to diagnosis, we might have been rock stars and been able to hold and retain 7, 8, 10 pieces of new information and gone about our day and incorporated them and done what we need, do what we need to have done. But a lot of our patients now can only take in 2 to 3 pieces of information at a time. And so I tell them, know that and don't set yourself up for failure. Advocate and tell others, if we're gonna do more than 2 or 3 things, I need to stop, go and get those done, and then come back and give me more, especially for my patients who are still working. They need to parse down what they're doing. Landing pad. I wanna talk about has anybody heard of what a landing pad is? Okay, so a landing pad is setting a designated spot for your designated items within your work or within your home. One of the first things that my patients always tell me when I say, tell me about your memory problems, they're like, I lose everything. I can't find my phone, I can't find my keys, I can't find, where I put the list that I'm supposed to remember. And so I tell them, create a landing pad. This can be, you can purchase them where they're fancy and they have all neat writing, but what I tell my patients, go get a label maker and write keys and put it on your table when you first walk in your house. Every time you walk through the door, you put your keys where it says keys. You put your phone where it says phone. It is a landing pad for all of your items and objects. And let's see, another one that I think is really important, I use this one. Use a single notebook for everything. I can't tell you how many of my patients come in, and the caregivers, and they're like, well, we have our notebook for this doctor, and we have our notebook for our work, and we have our notebook for our medication regimen.
Or no notebook.
Or no notebook, yes, for sure. It is so much to keep track of all of those different notebooks. If I walked over to my backpack right now, I have my notebook in there. It has everything in it, from my work to my research to my kids to my husband's things, and I keep that notebook literally wherever I go. Gone are the days of carrying around a clutch, because my notebook doesn't fit in my clutch, so I carry around a large purse or a backpack, because I'm not kidding, it goes with me everywhere, and everything goes in it. You can flip back in pages if you've forgotten something, you can cross things off if you need to. Having one single place for all the information is vital.
Yeah, so these are great strategies, and we know that there are organic reasons why people have memory concerns or attention concerns, but sometimes our emotions don't make it any easier to remember things if we're feeling anxious or having a lot of other things going on in our mind. So I was curious if you could talk about what are some other problems you hear above and beyond cognitive problems?
Yes. So because I'm a neuropsychologist, my primary role is to assess thinking and memory, attention, things like that. But I also maybe dabble in the mental health field. And for years of working with these patients, I've noticed 4 different areas of distress that my patients describe to me the most. The first is that initial shock. The, wait, I have what? And where did this come from? And what am I going to do? And it is truly, you see it in the patient and their loved ones. It is a complete form of shock. And then that actually quickly transitions over to sadness, this realization that this diagnosis is going to be with you for life, right? It is going to change your life, and it is going to impact you and your loved ones' future. And then as they start to go through their routine of treatments, they start to have this ongoing worry that has more heightened times, as you will see near the machine, scanxiety, this worry of, okay, so I'm going through these treatments, I'm doing everything the doctors are telling me to do, but what happens if it does come back, right? And my patients described to me this experience of recurrent trauma. That trauma, the first time they heard they had a brain tumor was because that machine told them that they have a brain tumor. And so every time they have to go back into that tube, they have this trauma and this fear coming up that they're going to hear that news again, which gradually, again, turns into this fear of, okay, so what if it does come back? What treatments am I going to have to undergo? What if the doctors tell me there is no treatment for it? And what does that mean for me? What does that mean for my family? What does that mean for my future?
Yeah. Mic drop.
Mic drop.
So these are big emotions, and what can people do in their daily lives, notwithstanding going to see a therapist, just like on their own? What can they do?
Yeah, so the first blanket statement is these emotions are normal. I don't know a patient that hasn't, to some degree, experienced one of these emotions. And oftentimes they're mild, and oftentimes they can be dealt with or lessen over time if you just implement normal behavioral health, daily living strategies. Exercising, again, is a big one. Getting enough sleep. The way I look at sleep is it recharges our brains. So we all use our phones, right? And what do we do at the end of the night when we go to bed? We charge our phone, because if we wake up the next morning and our phone isn't charged, it's not going to work optimally. At some point in the day, it's going to shut off, and we're not going to have it. And I look at sleep the same way for our brain. It needs to recharge so that we can perform optimally the next day. So getting enough sleep, getting outside, spending less time on the couch or in bed. Go out and do new things, explore new adventures, learn new things. That's great for our brain. It's great for our mental health. But with some of these day-to-day strategies, they're not enough. Some of our patients do experience more moderate or severe emotional distress. That sadness starts to impact their day-to-day life. That anxiety, that worry, that fear starts to stop them from socializing with their friends and their family. Some of them stay inside and don't go out and participate. Some of them can't work, and they need more strategies to cope with that. The good news is we do have a lot of evidence-based treatments that can help with mental health, with clinical depression, with anxiety or fear of the cancer coming back. Some of our patients experience death anxiety, and there are evidence-based treatments out there for it. Anywhere from relaxation skills, deep breathing, mindfulness, meditation, to more advanced skills that you actually go see a therapist for, and they go through a manual a couple weeks, a couple months of teaching you strategies on how to reduce that distress.
Yeah, and I know we're going to show some resources at the end where people can get connected. I just want to pause. Who here has received a neuropsychological evaluation that you know of, where you're sitting, and they're testing you for hours? It's torture.
I'm sorry.
It's torturous. She does that.
I mean,
not
it's a
me.
wonderful thing, but it is a thing.
So what
to go through.
if people haven't had one of those, or what if they're interested in therapy?
Yeah.
Either one of those things.
No, that's a great point, because honestly, there's not enough of us out there. I know for neuropsychologists that work in neuro-oncology, there's only about 10 to 15 of us in the country that truly specialize in brain tumors and do what we do. And so if you're not at one of those very robust academic medical centers that have a ton of resources, but rather you're at a community hospital, you need to advocate for these services, because they might not have someone like myself or Dr. Willis on staff that you're automatically going to see as standard of care. And so my recommendation is to ask your physicians and ask your team, where can I get support? There are clinical psychologists that may not be specialized in brain tumors, but might understand the depression or the anxiety or the cognitive problems that you're going through. There are social workers. They're like clinical psychologists and mental health providers. Chaplains are also a great resource. So ask, where can you send me within the community that I can find these resources if you don't have them as standard of care as part of your program?
Yeah, and I know ABTA has great resources to get you connected to either neuropsych testing or psychotherapy.
Right, and the peer-to-peer support that ABTA has is fantastic. Having somebody counsel you that has walked your journey before, that has stood in your shoes and heard that diagnosis, watched a loved one or another patient, I went through what you've gone through, can help tremendously.
So I'm curious, we both work at the Live Now lab. I'm at Mass General, but I'm still plugged into Live Now. What are we doing about some of these problems? What opportunities exist for patients now?
Yeah, so another thing that has been wonderful, so originally when I started Live Now, we provided therapeutic, cognitive interventions for our patients at VCU. COVID happened, right? Which was awful in so many ways. But one of the wonderful things that happened with COVID is it allowed virtual to come into medicine. And so we have expanded almost all of our trials virtually now, and we are nationwide recruiting for our trials. So we have an ongoing trial right now for patients who have solid tumors that have spread to their brain, so brain metastases, to help them live meaningfully and purposefully in their life while knowing that they have a life-limiting disease. We have a project called Fearless that we just heard we are getting funding for. Very exciting, but that is helping to reduce patients' fear of cancer recurrence. So that's the anxiety that our patients are experiencing. It is a 10-week program. Again, they go through virtually that helps them reduce that fear so they have the coping skills every time they're told it's time for your MRI again. And then I'm going to give you a shameless plug right now. We do actually have one that's actively recruiting. Also, this one we just launched our new trial about 2 months ago. So this is cognitive behavioral therapy for insomnia. We know that 25-ish% of our patients experience clinically significant insomnia symptoms. And 70% of our patients have some kind of sleep disturbance that impacts their daytime functioning and their daily fatigue level. But you tell them what we found when we asked them whether it was getting their medical team was helping them and what kind of treatment they wanted.
The majority of people who had insomnia said that this was not being addressed by their medical team, which understandably so. Your neuro-oncologists are trying to provide the right medical treatment for your tumor, and they just have like a lot of balls in the air. And at least half of these patients were interested in a behavioral treatment for sleep instead of taking another medication. And CBTI, cognitive behavioral therapy for insomnia, is actually the gold standard treatment for insomnia, no matter if you have a brain tumor or for any person with insomnia. So we've looked at this in a small sample of 44 patients. There's no control group, and every person had insomnia at the beginning of this treatment, and at the end,
6 weeks later, that's all the intervention is. None of them met the severity for insomnia anymore. This is a well-evidenced intervention. It has been studied and shown effective with healthy populations, medical populations, oncology populations, but has never been done with patients with brain tumors.
I'm curious patients and caregivers, if you feel like your sleep is suboptimal, I'd love to see another show of hands. Oh my goodness.
Look around the room. I mean, this is a significant problem in our patient population, and right now we're not providing the gold standard of care for it. So we are trying to enroll 60 participants to go through our randomized trial. Half will receive the intervention. Unfortunately, the other half will serve as the control group, but because we're clinicians and I can't just let them not sleep well, at the end of the study, they will get all of the materials, including all of the PowerPoints and voiceovers and handouts so that they can go through the intervention themselves. So we've had this open. We're recruiting nationally. We have people from Chicago. We have people from California, Florida, Virginia, obviously. And again, it's a brief 6-week intervention. So email us or call us if you guys are interested. We're recruiting right now.
And I think y'all have probably heard a lot about clinical trials in the medical sense the last couple of days. We do behavioral clinical trials. So we're trying to figure out what type of supportive care programs work and how we can embed them into standard neuro-oncology care, because we believe your quality of life matters just as much as your quantity. And so if you see opportunities like this nationwide and you feel like you want to get involved, to give back, look for those opportunities too, not just the medical clinical trials, because you're helping yourself hopefully, but also helping the next generation.
Right. So I'm going to stop talking about the patient because I've been rambling for, I see, 20 minutes. I'm going to hand it over to Dr. Willis, and she is going to take over the caregiver side of things. So,
this one?
Yeah, no, the big
one.
Yeah.
So I started working in neuro-oncology by being a therapist for patients, and I still do that. I find that very meaningful. And I wasn't interested in caregiving research or caregiving issues until I started sitting with patients and caregivers and realizing, oh my gosh, caregivers go through so much in silence, and the focus is often on the patient, as it should be, and at the same time, we're forgetting about our caregivers who are going through a lot. And so we started researching caregivers and learning about some of the struggles, and I'm going to share some of that information today.
Yeah, tell us about the challenges that you've seen your caregivers go through.
This is a short list. I'm sure I'm missing things. But just as it's a shock to the patient, it's a shock to the caregiver. And all of a sudden, you're a nurse, you're an advocate, you're a physical therapist, you're an occupational therapist. I mean, you're serving so many roles. You're taking care of kids, you're taking care of finances at work. You're doing everything. It's really hard to juggle so many roles at once and then also feel like it's not about you, it's about the patient. You're seeing changes in real time. You're navigating a very difficult healthcare system. You're calling specialized pharmacies. No one was expecting to do this at any point. And if this isn't obvious, there is no manual provided for being a caregiver. And what I often hear from caregivers is that they feel like they're not doing a good enough job and they could be doing more to support the patient. And it's a hard job. They live with this constant guilt as if they should know more. But really, you were never expecting to have to do this, and you're learning in real time. So it's a really hard job.
Yeah, they're being thrown into a role that they didn't expect to be thrown into.
And they're learning, and it's changing because
Yeah.
the tumor is changing.
Correct. So how do these challenges play into the caregiver's mental health?
Yeah, so we have started to look at rates of depression, anxiety, death anxiety. So when I say death anxiety, I mean that constant preoccupation where you're worried about your loved one passing away or losing them physically or emotionally. And we have found higher rates of these things, depression, anxiety, death anxiety, in caregivers than in patients, which is really profound. If you're a caregiver in this room, tomorrow I'm speaking at 1, and I would love to see you there. And it would be great if you could come by yourself, if that's possible, and just a space just for caregivers. So it's not just these emotions, it's also your health. You're not sleeping well, your stress on the body, makes you more prone to being sick yourself. There's a lot of emotional and physical health concerns with caregivers.
So we have patient that needs to be cared for. We have a caregiver that needs to be cared for. How does that play into the dyad relationship?
That's a really good question. So one thing that I hear sometimes is patients and caregivers are dealing with the same storm, but they're in different boats. And
It's a good analogy.
yeah, and in some ways they are, right? The patient is dealing with some of these cognitive and medical changes in real time, and the caregiver is adapting. But what I hear, we found this in our research actually, is that the patient is afraid that they're a burden to their family. And the caregiver worries that if they bring up their feelings, they're burdening the patient. Like everyone's worried about being a burden and no one's talking. Mm-hmm. And we have found it quite powerful to bring the patient and the caregiver in the room together in psychotherapy and to get them to have some of these difficult conversations that we don't naturally have in our normal day-to-day lives because life is so fast. And so I would recommend, if you're not in any sort of formal psychotherapy, could you find a way to sit down on a regular basis and have some of these difficult conversations? Like, I'm scared about my next scan. Mm-hmm. I'm scared. I feel like I'm not doing a good job. I feel like I'm having trouble at work and being a caregiver. I feel like I'm not there enough for you. Like, whatever those things are. And once you're able to talk with one another, that's when you together can start looking at your support system and identifying, okay, who in my life could give us that practical support? Who can drive me to appointments? Who can bring us meals? Who can we ask questions about what this next stage of treatment looks like, or about this clinical trial, that informational support? Who can I talk to and just vent my emotions that are ugly and honest, like especially the caregiver, like who can you talk to and just be yourself? Maybe it's financial or respite support. We know caregivers need breaks, and that's not because they hate their job or they're not good at their job. It's just because they're human beings. And so talk to one another, figure out support with each other, give each other grace. Y'all aren't supposed to know how to do this perfectly. And you may not get it right perfectly, One of you may make a mistake, one of you may be irritable. Give each other grace to navigate this together. I think there's a missed opportunity when two people are struggling in isolation, when they could be struggling together and supporting one another. And in those struggles, find small, brief moments of joy. So you don't have to plan this perfect trip to Italy because you've never been. Can you giggle in your hotel room together tonight? Can it be something just small? Can you go down memory lane together?
Hold hands on the couch.
Absolutely. I'm
serious, like go for a walk, right? Things like that we can incorporate and find those meaningful, purposeful moments of joy living side by side and not just breezing through this life. We talk to our patients a lot about there's so much distress that comes with this diagnosis. But there is one, if I can say this, blessing that comes along with this diagnosis, and it is forcing us to stop in our tracks and realize that life is precious. right? And time is short, and we don't know what tomorrow brings. So let's live purposefully and meaningfully today and make sure that today counts every single day. And I know that I did not do that before I started working with this population 10 years ago, and my life has changed since working with you all.
Amen to that. Amen to that.
So I do have a question, Dr. Willis. This would be great if patients and caregivers lived in a silo, right? But life still is going on around them. So what happens when there's kids involved and there's other family or friends that love you but are trying to get time and attention and trying to ask questions, and somebody has to go to work during the day? How do you incorporate all of that into trying to stay sane, honestly?
These are great questions. There's not going to be a one-size-fits-all answer, and I hope that someone asks a question about this if they feel comfortable. You know, I think the first thing is you get to choose what information you want to share and what information you don't want to share at this time. A lot of times the caregiver is the liaison person in between the patient and everyone else. That could be other family, kids, friends. Sometimes it's helpful to have another point person besides the caregiver help disseminate information. That could be an email chain, it could be a blog, so that you're not repeating yourself so many times. With those that you choose to share information, like thinking about kids. One thing is to look for resources in your community. A lot of cancer centers have parenting centers for people who have brain tumors or cancer. Which can be useful. Think about the developmental age of the child. So, you know, if it's a young child, maybe it's a need-to-know basis of what's going on. Mommy is going to look a little different. She's going to have a new haircut. She's going to rock the new haircut. Maybe if it's a 17-year-old, it's a different conversation. Kids are smart, teens are smart, they notice changes. So I would say probably say something that's appropriate.
And the older ones have access to the internet. So having, you know, allowing that conversation between your family before they go down the rabbit hole of Google might be a good thing, because kids are getting phones these days at first grade, second grade. My kids had to wait till 8th grade. They hated me, but you know, if your child has a phone, they have access to look things up, and they're smarter than we give them credit for. So
and we don't want them to have the wrong information.
Right.
Usually when you don't have all the information, our brain likes to catastrophize and think of worst case scenario. So it's probably better for you to be the one to give them the correct information. At work, you know, find an advocate. Maybe it's HR, maybe it's not. Maybe you're connected through a peer, either a patient peer or a caregiver peer, and like, how did you navigate work? And again, it's what you feel comfortable sharing. A lot of our patients or a lot of our caregivers take FMLA, and that's okay. You can't do it all.
Yeah. Give yourself grace in addition to each other grace.
Right.
Yeah.
So those are just a few things, and we wanted to leave y'all with one message. Speaking of things like grace, living in the present, which is the name of our lab, Live Now. We wanted to leave y'all with hope, which is the theme of the ABTA, because we've talked a lot about problems, cognitive problems, emotional problems, but as Ashlee poignantly stated, we are so inspired by the resilience of our patients. It does not get old. And we did a qualitative research study of patients, and we had them talk about, like, what are these cognitive emotional challenges, and they told us all the things we've told y'all, but we didn't even have to ask about this, and they told us about hope. So we wanted to leave y'all with something else we found in our research, is how important it is to have hope, and how hope can look a little different, and that's okay. We are so inspired to hear about hope for a cure, hope for each other, hope for more time, hope for strength to get through this challenge in our life. And we are just so touched by the resilience and the hope. And so we did want to leave y'all with that positive message. Did you have anything you wanted to add for this one?
No, just don't give up that hope. It's about balancing, right? Understand what the diagnosis is and what the trajectory is, but we are continuing to fight right alongside you guys. And so don't give up that hope. Keep believing, keep coming back, and we'll fight together.
Amen.
We went over our time. Do we have time for questions, or did we talk too long?
We will
was
stay.
Flashing at me while we were talking.
Okay, and why people ask questions, there's resources somewhere to be found.
Thank you. Thank you. Hello.
There you go.
All right, there you go. Thank you both so much for that amazing session. We do have time for questions. So just as a reminder, you can submit questions on the app. For those of you in person, just click Session Q&A, select the right session, and submit those questions. For our virtual audience, the Q&A button will be on the left of the video screen. If our in-person attendees, if you guys have questions and you would prefer to just raise your hand, go ahead and raise your hand and we'll walk over to you with the mic. So I see we have a couple questions here. We'll start right over here.
Thank you for sharing your perspective. It's been very helpful to hear. The thought of living in the moment and the now and trying to make every day count sounds great.
Yeah.
But it also, I feel as a caregiver, puts an undue amount of pressure on me to make every day really fucking count.
Yeah. Great point.
I'm wondering if you can talk a bit about that and how maybe it's okay to have normal days too that are just kind of
So
like
that's what I was about
typical
to
for
say.
people that don't have brain tumors and not have that pressure.
Yes. So when I say make every day count, I mean finding joy and pleasure in the normal, because there's a huge blessing in that. Like I said, when you're sitting on the couch reaching over and holding your wife's hand, that might have been just a thing you guys did, but now is meaningful, now is special. But also, yes, living in the normal. There are ups and downs of this diagnosis, and having those times of normalcy, is that the right word? Normalcy. She's so much better at it than me. See, we all have issues with our brain. Those moments are to be celebrated too.
I have to talk about double awareness.
Go. Do it.
So there's a term called double awareness that we use in this psychology jargony world. It's the idea that you have to balance two competing, opposing things at once. You have to have every day is a blessing, and then you have to have mundane life. You have to be thinking about the tumor, and you have to be thinking about what you're gonna have for dinner that night. You have to be thinking about the future and planning ahead, and you have to be living in the now. You have to be afraid, and you have to have hope. You have to walk a tight line. And we encourage our patients to not veer one way or the other. So if they're spending too much time in the present and they're not planning ahead, that's not great. But if they're also just thinking ahead and they're only thinking about the tumor, that's not great either. So you're right. It's great to do. You can't do it every day. Give yourself grace to not do it every day, and hopefully there's moments in between.
Yeah, and try to work on that balance, right? Like there's some days where you're going to be able to give 20% and some days 80%, and that's okay. You're doing the best you can. You're here. Great question. And we have one over here as well.
I have a question, and I've been pondering this for 21 years, and okay, thank you. Because I had my tumor surgery and radiation treatments in '03. When I started the journey in '02, what I found, and this was in Iowa, but even at the U of I, what I found to be true at that point, the doctors, none of them radiation oncologists, neurosurgeon, even the neuro-ophthalmologist that had the CAT scan done and found the tumor, none of them tell, at least in my case, tell the patient anything. And so in my case, I realized it pretty early on then, I did need to go to Google. I did need to study books. I did need to look up from Cleveland Clinic or other institutions of what they could tell me about my second stage meningioma. I had to know that so that when I did come for an appointment, I could ask the right questions. It seems to me that that is going the wrong direction. I would like it if all the doctors involved in the brain tumor world all over the U.S. would put together some kind of information packet, or if they are willing to take the time, then when they meet with that individual patient, tell the patient, we'll tell them the steps that you're going to face as you go along in the beginning. Then do it again once you're further along in your journey. Tell us. Don't make us to go and search. Maybe, I wonder, at the time, I bet I searched for maybe 10 hours altogether.
We agree.
Not at the same time, but, and I mean, why are they behaving like this? They're brighter. They're bright enough to do neurosurgery, back and brain. They're that intelligent. And why are the doctors this way?
I think some are trained in specific tasks, which is to cut the tumor out, and that might be it. I think some are trained to save your life. And when they don't have a cure, it is difficult to have those conversations. 20 years ago, they weren't incorporating these conversations into medical school about how to have these difficult conversations. I do think that is changing. I do feel there is more information being given. We as psychologists are hounding them all the time about what did you tell them? What does the future look like? But there are some, to be mindful of everyone, there are some patients and caregivers that don't want to know, honestly. And so as a physician, you're stuck trying to figure out how much information do I give so that they're educated, but being mindful of the state that they're in and what can they receive and what are they capable of coping with when they receive that information. And so what I tell my physicians is ask the patient and caregiver, here's the series of information and the knowledge I have. What would you like to discuss today? Let the patient and the caregiver have the ability to lead that conversation. Allow the opportunity for that discussion. But you don't have to shove everything down their throat as soon as they hear they have a brain tumor. Honestly, they're not going to hear it anyways at that moment. So giving it in doses, but also letting the patient and caregiver the opportunity to ask the questions without giving too much information right away.
You don't know what to ask because you're not.
Right, I understand, but when you can prompt that as the physician. So what would you like to know about the next steps of treatment? And would you like to know about if the tumor is going to come back?
Thank you so much for that answer. I know we have one more question over there, and I think that will be the last question that we have time for.
Hi, first of all, I just want to say your presentation has been great, really positive and really helpful. My question is kind of a niche question. I was wondering if you have any tips or resources for a patient who is 19, who had, when she was diagnosed, had the 1 in 1,000 chance of being diagnosed with a brain tumor, whatever the statistic is, and then has been doing really well, but then whenever there's another condition that comes up, like any physical condition, kind of goes to the worst case scenario. I would think that would be just a logical thing where the brain could go, even in this particular person even is a psychology major who, you can rationalize that shouldn't happen and that's not the case. But do you have any ideas or resources to point?
Yes, they need fearless. That's our intervention. What you're talking about is hypervigilance. So in other cancers, it looks very different. In breast cancer, patients will feel their breasts 100 times a day to search for that lump. Melanoma will search their body for any skin tags or, skin deformities, changes in the color, but we're not touching our head, right? But we're counting how many times we forget a word. We are worried if we have a seasonal headache that it means the tumor is coming back. There are specific, honestly, mindfulness works really, really well for this, learning relaxation and mindfulness techniques when that happens, but also allowing yourself with a therapist to go down that road, find out what your worst fear is, and then work your way back. Because honestly, the worst fear is usually not logical. It's actually not the way it's going to end up, and helping them work through that. So contact us at our lab. When we open Fearless, this is a perfect program for this young adult.
And I just have to say something too. We go worst case scenario to protect ourselves. It's actually an adaptive skill to do that, but it steals our joy, right? And so what I would say is it's totally normal to have those thoughts. We just have to catch them and find a way to center ourselves to the present moment and remind ourselves that I'm worried about this. Thank you, brain, for this worry. It may not be true. It's a thought. It's not a fact. So there's nothing wrong with having these types of thoughts. They're here to help us. How much weight and control we give them on our lives, that's where the work is.
Yeah, perfectly said.
Thank you so much, both of you, for your wonderful answers to these thoughtful questions. We're going to go ahead and turn it over to Emily for the rest of the program.
Yes, I just want to say thank you so much, Dr. Loughan and Dr. Willis, for this incredible session on quality of life for both the patient and the caregiver, and it's been an honor to work with both of you. Give them one more round of applause, please. All right. It is my honor and privilege to introduce our keynote speaker. He is a 29-year brain cancer survivor and provocateur hailed for leading a social movement for young adults with cancer. He founded the award-winning nonprofit organization Stupid Cancer, the world's largest AYA cancer community dedicated for empowering young people with support and connection. He hosted the first health